Hey everyone, thanks for joining us today to talk about leveraging HCCs for quantifiable financial results. My name is Scott Everett. I'm the Vice President of Healthcare Solutions with Practical Data Solutions, and I'm joined here today by Kelly Constantinidis, our Senior Business Intelligence Analyst. Thanks for joining me today, Kelly.
Hey, thanks, Scott, and thanks everyone today for attending.
So, Kelly, as HCCs becomes more of a prevalent discussion point in the healthcare industry, something that people are seeing a lot more of, value-based contracting coming into play a lot more. It'd really be great if we could really take these risk stratification scores that are out there and be able to identify our patients who are at the highest risk, start looking for gaps in care and things like that. And ideally, when we do have value-based contracts, we can start projecting out revenue that way if we have this information at our fingertips.
Yeah, so Scott, let's just talk about some HCC risk scoring items. So I heard you just say value-based care contracts. So that's part of it. But some people think that risk scoring in HCCs is just a Medicare thing or a value-based care thing or just for primary care. So we really want to dispel that as a myth. And one of the things we want to really emphasize today is that it's important to evaluate all patients for risk, not really just those certain subsets.
Yeah, that's a good point. So let's take a look at a population. Obviously, as a provider, you have some sort of population that's attributed to you as a as a physician that's caring for their conditions, and usually this population is pretty good about reaching out to us whenever they need us. But within that population, you will have some people who may have higher acuity of care. Some people have chronic conditions that need to be treated, and they may not be reaching out to us until things become negative or even a little bit too late. These are the ones that we need to look at, and that's why it's important for us to really understand the entirety of our population. What risk scoring is good for is really stratifying the population that we have, identifying those at the highest risk, and we need to understand our whole population. If we want to provide the highest quality of care, we need to do it for everybody, not just those in value-based contracts. We need to do it regardless of age. We need to do it regardless of insurance, regardless of the plan that they're on.
So once we understand that patient population and we know some of those patients that may need more services, we can start to identify gaps and work to close those gaps. So this is an ongoing process as patients' needs change, as their risks change. We just need to continue to reassess and to close those gaps.
Yeah, so as we dig into this, Kelly, let's kind of start at the beginning. I know we have some people here who may be just wading into the HCC waters right now, and we want to begin with, at the very beginning for these folks. So let's talk about what we mean by HCCs and risk scoring. So HCC stands for hierarchical condition categories, okay? What we're talking about this are chronic conditions that our patients may have. So we're looking at the ICD-10 codes that are out there. And obviously we have, over 72,000 ICD-10 codes, but not all of those map to a chronic condition.
Yep, just about 10,000 of those map to one or more HCC codes. And there are 86 HCC codes today, and we can further categorize those or group those together into about 20 categories. So let's break this down for a patient.
Okay, yeah, so these condition codes and these risk scores are really based around cost, okay, and where would they feel the risk for patients are around cost. So this is a concept that's out there, but we don't deal with concepts in healthcare, we deal with patients. So let's talk about Bob, okay? Bob's a 78-year-old male, he lives in Florida. Bob's on Medicare as a 78-year-old male, but also is Medicaid eligible as a secondary, and we'll show you why that's important in a second. Bob is diabetic. He has had some vascular manifestation with his diabetes. He's also obese, and in his past couple of visits, he's had some chronic heart failure that's been detected as well. So when we look at Bob, we're going to utilize these scores in order to determine Bob's risk.
Yep. So based on age and gender, we're going to assign Bob a score that's going to get higher as Bob gets older. And then for chronic conditions, Bob's going to get a score for each one of those, or a value for each one of those. And then if some of those diseases interact with each other, there will be additional points because they maybe have to treat those at a higher level. And then adding all of these factors up, we're going to get to a risk adjustment score for the patient. And I do just want to point out, Bob is a Medicare patient, but we really want to score all of our patients. We probably have younger patients with these chronic conditions.
Yeah, so these risk adjustment factors, again, factor into, cost of care. And that's how these were set up by CMSs to determine that. So if we really dig in and take that risk adjustment score of a 1.4 that Bob has, and just for reference sake, when we look at assigning risk, usually a patient that's less than a 1 is considered a low risk patient. Patients that are between a 1 and a 2 or thereabouts are considered moderate risk, and anything above a 2 is a high risk, okay? So if we take Bob's score, Bob is a moderate risk patient. We take his county that he lives in Florida. They have found, CMS through studies has found that typically someone with a risk score of 1 in his county would have a cost of care annually of about $7,700. Okay, so if we take Bob's risk score, multiply it by that $7,700 cost benchmark, then what is allocated for care for Bob, or that's what it's called, is $10,777. Okay, now is that what the provider is going to get for Bob? No, it's not. But there are ways that this cost benchmark and this allocation for care is utilized within the value-based plans that are out there. So let's look at some of these value-based plans that are utilizing these risk scores and cost benchmarks for reimbursement. Obviously, the one that most are familiar with are Medicare Advantage plans. And these are becoming even more prevalent out there. And what these are, and the way they utilize it, is they take these risk scores, and these risk scores are multipliers for capitated payments that may come across for, depending upon the contract that you have with these Advantage plans, okay? So the higher the risk, the higher the reimbursement that's going to come across here. In addition to that, there are several value-based commercial contracts that utilize these risk scores as part of an incentive payment calculation for the providers that are out there utilizing these contracts. If you're on a shared savings plan, those ones utilize HCCs and the benchmarks to determine if the provider is able to keep the total cost down below the benchmark figure. They can share a certain percentage of that savings with the provider network. And then same thing with bundled payments. If your network accepts bundled payments, then HCCs are factored into those bundled payments based upon your contract with the provider or the payers that are utilizing those. So we look at all of these different plans that are out there and how HCC can factor into those.
So our payers are assigning risk scores to our patients. And there's a perception that, since we document everything in the electronic health record, that all of the clinical documentation makes its way over to the insurance company, and that they then have a total picture of the patient risk that matches exactly what we have as patient risk. Well, generally what really happens is from the electronic health record, we send documentation to coding, then it goes to billing before a claim is actually created. And then generally those claims are going to go through a clearinghouse before they make it over to the insurance company. And then at the insurance company, whether it's in the claims department or they have a specific risk department, they're the ones that are going to assign that patient risk score.
Yeah, and Kelly, I think it kind of points out that the insurance companies are utilizing this claims data to assign their risk. And as we create a claim, every single step that you pointed out there is one where there could be a potential fail point where not everything's coming across. So if you look at, you know, something internally where maybe we're missing a code, or you know, something happens in the billing or charge entry process. If we're looking at the clearinghouse, we've seen instances with clients where we're working with that sometimes the clearinghouse will strip out all but 8 to 12 diagnosis codes, and there are, you know, relevant diagnosis codes beyond that on these charges, which are simply getting ignored. Or even on the payer side, before it gets to the risk, if the claim is denied, then none of those diagnosis codes are getting scored with the risk factor. So all of these potential issues are out there that would keep the codes from being what we would expect them to be. So in an ideal world, what we would be doing is we're taking the data that we're getting back from the insurance company and we're matching it up with some sort of internal scoring that we're able to do, where we can say, here's what we know is going on, and due to one or more of these different issues with the clearinghouse or on the payer side, we want to be able to reconcile what we know is going on with what the payer tells us is going on, and be able to, especially if we have a value-based contract, kind of maximize that reimbursement that we're getting from them.
Right, but we also can use HCCs with fee-for-service contracts because we're going to be able to work to identify gaps, which are going to impact quality. And at the end of the day, we want to provide better services to those patients that need that care.
Yeah, and Kelly, I think that really helps us understand that point, that this isn't just for value-based contracts, and it's not just for Medicare. We want to be doing this for everybody, because even with our fee-for-service payers, we can find ways to increase and improve the services available to our chronic care patients that are out there.
And you know, risk scoring is also going to allow us to better understand our care team requirements. We can better know our staffing and utilization patterns, and because we want to score all patients, we can start to, you know, we're going to score all the patients. So we can then carve out segments of the population and look specifically at the value-based care contracts, current and future ones. And then we can, you know, use this information as we look to plan for growth for the future.
Yeah, so we talk about needing to do risk scoring, and so that begs the question then, where are we going to get the data from on our side? Okay, so obviously the thing that comes to mind is the EHR, because that's where we have the most complete record of all of our patients. That's where our complete problem list is, that's where our medication lists are, that's where lab results and everything else is. But the EHR data is really difficult to get this information out of. It's not necessarily structured for this type of reporting. It's not coded. It's not, you know, necessarily very accessible to just any user. And so we found that using the EHR data is a little bit difficult. So the next place people tend to look is on the payer side of things. And when you look at it, payer data is what most people are using now. But when we start talking about, you know, the need to do every patient, you know, the payer data is limited. It's not coming back in a timely fashion. Sometimes we get it quarterly, sometimes semi-annually, if we're lucky. And of course, since we want to do it for everybody, it's not going to have everybody. It's only going to have the subscribers to that insurance. So, you know, when we look at it, I think we've found a better way.
Yeah, so we can actually use the utilization data right from our billing system. We can see when patients were seen, what CPT codes were billed, and what diagnoses codes were billed on those charges in order to have our own data set for risk scoring. So we can take that information from each one of those encounters, and if a patient qualifies for one or more HCCs, we will assign a total risk to that patient. And that all rolls up, you know, we have all the detail around that charge data, like the practice, the provider, and the payer data, we can start to look at that patient population either by risk level, provider, practice, and focus our efforts there.
Yeah, and this is the way that you like to look at it from the standpoint of having all of these different roll-ups, again, being able to understand our populations. Now, risk scoring, again, takes that information that's out there and it involves joining it to, a couple of different CMS tables. It can get a little bit tricky, but really this is the end state for what we want to get to, because this is what's going to give us the most comprehensive view of our patients and help us to better care for them. And let me show you what we're talking about. Let's go back to Bob for a second. Okay. So Bob, we know, is a moderate risk patient that's out there. We want to be able to make sure we're providing high quality care for him, but we haven't seen Bob in 9 months. Okay, Bob, as a diabetic, has not had a recent hemoglobin A1C test for over 18 months. And according to our records that we have, he's got 2 prescriptions expiring, and that could be really problematic depending upon what those are. So we want to make sure that we're getting Bob in, and maybe Bob's not that great about contacting us. I know last time he was in, he mentioned he doesn't like scheduling appointments online. It's confusing for him. He's not really great using the internet. He tried calling, but the phone tree was confusing and it wasn't something that, he was willing to wait for. He wanted to just talk to a person. And, even though we tried, we may not have even scheduled him for a follow-up last time he was in the office because he didn't have his calendar with him, so he didn't know what to do. So, when we look at things like this, that can cause problems when we have patients like Bob that are of the higher risk variety if they're not coming in to see us. Because what's going to happen to them, Kelly? They're going to get sick. Okay, when wellness isn't being prioritized by the clinic or by Bob, he's going to get sick. Now, when he does, hopefully he'll call us and try to get in. And if we have good availability, same day, next day, we'll get an appointment scheduled and things will be fine. But we also know that a lot of the clients that we're working with, they don't have that availability. They have, some limits attached to that. And so if Bob calls in and he can't get in right away, he's going to go somewhere else. He'll go to urgent care. He'll go to another provider. He'll go to Walgreens. He'll go to Walmart. Or worse, if he's feeling really sick, he goes to the ER. Or even worst case scenario, Bob gets even too sick to care for himself. And now we're looking at ambulance, ER, probably leading to an inpatient stay. And that's where we really need to make sure that we're prioritizing wellness in order to get to the best outcomes.
Yeah, so we have more opportunity when we prioritize wellness. So while it's great and we want to continue to encourage the patients to be proactive and reach out and schedule those wellness appointments as a practice, we can also start to use an outreach approach. And this, regardless if the patient's, reaching out or whether the practice is reaching out, we'll have that flexibility with scheduling where we're going to be able to meet patients' expectations better, and they're going to be able to see the right provider, and they're going to get a more convenient appointment time. And at the end of the day, the patient will be more likely to show up. And then, hopefully all of, the wellness, the focus on wellness is going to prevent the patient from getting sicker, lower inpatient stays, and at the end of the day, lower costs.
Yeah, so one of the things practices may want to look at or start moving towards, and particularly with the patients at the higher risk scores, is starting to determine, where are our appointments coming from and what level of proactivity do we want to have as a provider clinic. So we can just start looking at where are, how are our appointments being scheduled? We can look at how many are scheduled via inbound call. We can look at what's being scheduled versus, an online patient portal scheduling that comes across. These are what we consider to be, patient-driven appointments. These are where the patients are contacting us, whether they're sick or whether the patients are wanting to get in to manage their own health the way we like them to. But then we can look and see where are the cases where the clinic was being proactive in scheduling as well. So we can see what was scheduled in clinic, where we're looking, you're in for one appointment, they want to schedule you 3 months out, 6 months out. You know who's great at this? Dentists. I'll have the dental assistant come in while I'm still sitting in the chair. The guy hasn't even taken the pointy stuff out of my mouth, and she's trying to schedule my next follow-up in 6 months. This is one way that we can be proactive. Additionally, we can look at, if we're reaching out to our highest risk patients in the clinic and doing outbound calling to try to get them in, that's practice-driven care. That's where we're being proactive and we're trying to provide the highest quality and level of care that our highest risk patients need.
And Scott, because we have identified, or can identify care gaps based on, the HCC data that we've collected, we can focus that outreach on, patients with HCCs with no care at all during the last year, or maybe we've seen them but haven't documented that condition. We can also focus on patients that are missing wellness visits, Medicare wellness visits, annual wellness visits, and those that are not scheduled to be seen with an upcoming appointment. So this is a work list type report that we have you can see the full picture of a patient and the conditions those patients have been coded over the past few years, and quickly identify if we've missed documenting one of those conditions this year. And we can look at it by payer, provider, patient's most severe condition, that type of thing.
Yeah, and when you have detailed information like this, a lot of times it's useful to kind of roll that up and start looking at the practice as a whole from a more management perspective, where again, we can start looking at where are our highest risk patients. Who are the ones that we know we've scored this year because we can see a higher score or a similar score to what they had last year. This is really a key because those scores reset every year. Amputated limbs grow back, diabetes gets healed. It's a Christmas miracle every year from an HCC standpoint with CMS. So looking at, patients with the care gaps who hasn't been scored is something that can definitely be useful to make sure that we're identifying those who haven't been seen in the past year.
And this visualization is a quick way we can focus on patients that may not have or that are past due for a wellness visit. So we can generally identify, wellness visits based on the CPT codes that are billed and the subset of those CPT codes that are reserved for annual wellness visits. And then we can, start to see if they've had one of those wellness visits in the last 12 months. We can bump that up against scheduling data and say, well, if the patient has an appointment in the next few months, then we're probably okay. But if not, we want to, get them on our outreach plan. We can also look at, because we're looking at the patient as a whole, we can say, well, let me look at just my high-risk patients or my moderate-risk patients. Maybe I need to look at a specific provider, and maybe we have specific payers where we've got non-compliance with getting the patients in for wellness visits.
Yeah, and I know something like this, even this can be kind of overwhelming, where there may be a lot of patients out there that we need to reach out to. If we need to stratify it even a little bit more, we can start looking at maybe some care acuity that's out there where we do have high risk patients, and in the previous year, some have had one or more ER visits, or some have had one or more inpatient days. Regardless of the level of risk that they have, if they're higher risk or moderate risk, these are definitely ones we want to reach out to, because these are ones who have had an adverse adverse event happen in their life within the past 12 months, and getting them in for wellness care to help them make sure that they're managing those conditions that they were in for should be a very high priority for us to do it in a much more controlled setting.
And there may be some financial opportunity for getting these patients in and getting more patients in for wellness visits. So payers typically provide for an annual wellness visit, and it's an ideal opportunity to address the chronic conditions that those patients have every year. And with a population of thousands of patients, revenue opportunity for those extra wellness visits may be significant. And with this particular report, we can kind of see, okay, what happens if we bring all providers up that by about 15% to increase those wellness visits that we're seeing? Or maybe we can grab a subset of the providers that are seeing less wellness visits, and if we bring that up to the department average, how much money does that net out to?
Yeah, and these revenue opportunity dashboards that you see is really, we've found a fairly compelling way to encourage change, because if we're going to do this, it's going to require change in the way that we do some of the things, and finding these opportunities is usually a good way to do that, particularly around these wellness visits. Like you said, there's a higher reimbursement for this than there are standard office visits, but in addition to that, we're not capturing all of the potential HCCs just through an office visit. Usually it's because the patient has called in for one problem or another, and we're getting maybe one or two codes. Wellness visits allow us to look at the entirety of the patient's medical conditions and get those appropriately scored, so that we can make sure that they're receiving all of the specialty care and all of the follow-up care that should be required for something like that. So I guess if we're looking to get patients in a little bit proactively, obviously one of the things that we hear a lot of, we're just booked solid. Our schedules are full. How can we do this? And again, this is where prioritizing wellness can really help us out in this area, because we can come in and we can take a look at, providers' utilization of their schedule templates or their available schedules. We can see which providers may have availability. We can look at specific times of the day or days of the week. And we can look and see, wait times, because again, we have more flexibility. The patient, when we're being proactive, or even when they're being proactive, they're not necessarily demanding to get in next day or day after. If we need to look, 3 to 5 to 8 days down the road, that flexibility is available to us. So we can do that when we're prioritizing wellness, and having this information ahead of us helps us to be able to find that information. So again, we're talking a little bit about change and making this, an initiative within your organization to be able to utilize these scores, to be proactive, to get these patients in, to get them appropriately scored, to get us understanding what's going on. And so obviously, anytime you're looking at initiatives like this, the first step is communication, and communication with the providers is a big thing. And this is a way that we found that communicates pretty clearly to providers the entirety of their patient panel, the numbers who have been scored with HCCs during the year, their average risk score, etc. Now, again, the focus of this type of report is to say, how many have we gotten in? Have we gotten everybody in? And ideally, we want to get as many people in and scored close to the first of the year as we want to, especially those with value-based contracts, because that's what's going to impact the reimbursement that we receive. But obviously we want to get people in and scored so that we can make sure we're following up with the required care that they have. So this allows us to look at who has been scored, what we anticipate has not been scored, what the provider needs to do between now and the end of the year in order to reach that goal. And as this becomes a larger initiative within medical groups, this is something that some of our clients are actually utilizing as an incentive piece to the provider's compensation plans. So trying to incentivize the provider for something that helps bring the network into compliance and achieve their financial and quality goals is definitely something to look at.
So Scott, managing that scoring and HCC coding is an ongoing cycle. But the first step in the process is to understand that patient population and the risk scores and, you know, the chronic conditions that the patients have. Those patients are going to require different care planning in order to allow us delivery for that care. And then based on those, you know, chronic conditions, the frequency of their follow-up is going to change. And again, it's an ongoing cycle to reevaluate what we're missing or where we can improve there.
Yeah, and I really think this speaks to, you know, what we're trying to say today, that if we've, you know, if we have you walk away from this webinar with one point, it's make sure you're doing this for all of your patients. Make sure you're understanding everybody's risk scores internally. Make sure that they're complete and they're thorough, and that we're looking at everything with the patient, not just, you know, what they come in for, you know, a diabetes checkup here, you know, headache there that turns into something else. We want to understand everything that's there. So utilize those wellness visits as best as you can. And then once you've identified that, that's when you're going to be able to understand the frequency of follow-up care that's going to be required, or what type of specialty care we need to make sure that we're referring them to. We want to make sure that that frequency is out there. Some may only need to come in once a year. Some may need to come in 2 or 3 times a year. Some may need to come in quarterly or even bi-monthly based upon the level of acuity and risk that they have. But what's important for us to understand is that the better that we provide care for our sickest patients, for the ones that have the highest risk, the higher the quality that's going to come about. And because we're doing this in the right way, that's also what's going to maximize our reimbursement. And I find it's also kind of funny sometimes, Kelly, how doing the right thing just tends to do that very thing.
Right.
Thank you, everyone, for joining us today. We really appreciate it and hope to see you at November's webinar. Thanks, everyone.
Thanks again, everyone.